is USMLE PRO, and we're going to do some question and answers with Dr. Ingrid. I'm Dr. John. Welcome to our live stream, which when you see it will be recorded. But if you have any special topics you want, we are more than happy to do it. We can also go over some real life cases as well from our experiences. We'll change the names a bit, mix it up a bit. What topic are we doing today, Dr. Ingrid?
We're gonna go for endocrinology.
Okay, so we're going to continue our endocrinology. The last video was about adrenal. Go ahead, let's start.
Okay, do you know what are the main types of signaling in the endocrine system? Do you know that? Okay, there are 4. The first one is hormones that are directed to faraway organs through the bloodstream. The second one are secretions from a cell, which is called paracrine. Affect nearby tissues and cells. The pancreas is an example where communication between close by cells are necessary for good functioning of the organ, right? Now the third one is the neurocrine secretions. For example, peptides go through the bloodstream from the hypothalamus into the pituitary. That's the one. Now the fourth one is autocrine secretions from a cell that goes to the cell receptors and regulates the action on that particular cell. So it's autocrine secretion from a cell that goes to cell receptor and regulates the actions on that particular cell. Now there is another question, okay?
Okay.
Do you know how steroid hormones affect cells? Steroid hormones
Are made from cholesterol. An example of those hormones are cortisol, progesterone, estrogen, testosterone, and aldosterone. Now these are lipophilic, and they are like that so they can go through the cell's plasma membrane. And they form complexes with receptor nuclear cytosol.
So they go from the outside to the inside of the cell.
Now those complexes activate mechanisms of transcription because steroid hormones rely on gene expression and protein translation. Now it may take a long time for the effect to be seen, hours to days.
Yeah, that's good. Do you know the mechanism of action of catecholamines and peptide hormones on the cells?
Catecholamines and peptide hormones are not lipophilic.
Yeah, so they cannot go through the membrane.
Yeah, so that means they're water soluble. Now they cannot cross the plasma membrane, as Dr. Ingrid says. They bind to the cell surface receptors. So bind to the cell surface receptors.
In the outside, yeah.
Then they inhibit or activate enzymes. Okay, this causes changes in the protein's membranes and mediate in cellular trafficking. It happens within seconds to minutes. Now, peptide hormones, and examples of that are insulin, parathyroid hormone, vasopressin, oxytocin, and ADH, can stimulate gene expression, but the effect is slow. Just remember the steroid hormones, polypeptides, are dissolved in the plasma, whereas esteroids bound to plasma proteins.
Okay. So, what are the type of cell membrane spanning receptors where the peptide hormones bind? So there are several, okay?
Okay, tyrosine
And
and
serine.
serine kinase receptors.
That's one
Yeah.
example.
Another one are the linked kinases receptors.
Yeah, the receptors link kinases.
And you got the ligand-gated ion channels.
And the G protein coupled receptors.
Yes.
Now, those ligand-gated ion channels are the fourth ones. So I'm going to repeat them for you. Tyrosine and serine kinase receptors. The second one is the receptor link kinases. Okay? G protein coupled receptors are the third ones. And the fourth ones are ligand-gated ion channels. Okay? Now, it's important to know that number one receptors, so tyrosine and serine kinase receptors, bind ligands, so insulin and growth factors. Now, the second one, receptor link kinases, growth hormone, prolactin, and cytokines. The third one, G protein coupled receptors to peptides, neurotransmitters, and prostaglandins. The fourth one, ligand-gated ion channels, neurotransmitters, and amino acids.
Now we're going to point out that the G proteins are a 5-star topic on the board. So you need to study the pathways for GS, GI, and GQ signaling, okay?
We're going to talk
You
about
should
that.
know the details of these pathways, including the predominant cellular changes that occur with activation. And that's what we will be discussing of each protein, such as cyclic adenase monophosphate, CAMP. Increase with GS activation, intracellular increases with GQ activation. Now remember, signal transduction by G proteins. G protein coupled receptors bind to various extracellular ligands that activate intracellular signal transduction cascades, leading to activation GS or inhibition GI of CAMP signal pathway, as well as activation of the phosphatidylinositol signal pathway, which is GQ. Okay, so that's very important.
So what are the receptors, again, the various hormones use?
Yes.
Okay? We're going to talk about CMP.
That's one we hear a lot about.
Yeah. So CMP receptors and then the hormones and related substances are LH, CMP, okay?
Okay, CMP, LH, FSH, ACTH, TSH, PTH, HCG, CRH, glucagon.
That's right.
Okay.
Now we have the receptor class CGMP. Okay?
Now CGMP,
NO, AMP.
Good.
Now IP3, GnRH, GHRH, oxytocin, and TRH.
TRH, very good.
Okay? Now, the steroid receptors are another kind of receptor class, and they are related to estrogen, testosterone. That makes sense, right?
Right.
steroid receptors. Estrogen, testosterone, glucocorticoid, vitamin D, okay, aldosterone, progesterone, T3, and T4, okay? Now we're talking about the last one, is tyrosine kinase.
Tyrosine kinase. Okay, and the ones that involve there are insulin, growth factor, IGF, PDGF, GH, and very important, prolactin.
That's right. Now, do you know how the receptor of tyrosine kinase transduces the message signal? So hormone agonist to G protein coupled receptors, GPCR, produces a trimer subunit complex, alpha, beta, gamma, to work. So you find 3 types of GPCRs, okay? Which is G protein coupled receptors. This is what Dr. John talked about. To be in a complex to work. So we talk about alpha, beta, and gamma. You find 3 types of GPCRs: GS, G1, and GQ. For all of them, okay, GS, GI, and GQ, the GI subunit, so G alpha subunit, exchanges guanosine diphosphate, GDP, for guanosine tryptophan, GTP, signaling the primer to separate. The dissociated G beta and G gamma subunit then activate or inhibit enzymes like adenylate cyclase and phospholipase, and ion channels like calcium channels. According to 2 distinct pathways, the CAMP pathway and the phosphatidyl inositol IP3 DAG pathways. Okay? Okay, guys. Do you know why is the total serum hormone levels not an accurate reflection of hormone activity? Actually, this one is less intense. So if the same hormone is attached to serum binding proteins, the hormone is inactive, right? Because it's attached to serum binding proteins. So the only biologically active hormone is the free hormone. Another factor that affects the activity of the hormone is the concentration of cellular hormone reactions available for binding and mediating its action. Okay? Now, do you know about the concept of negative feedback? And this is not too hard either. What is the feedback loop?
The feedback loop. Hormone synthesis release from a particular.
This talks about the hypothalamus, hypophysis, and then the organs.
It's regulated by the pituitary hormone, which is regulated by a hormone coming from the hypothalamus.
Exactly. So hormone synthesis and release from an organ is regulated by the pituitary hormone, which is regulated by a hormone coming from the hypothalamus. Okay? And then we talk about hypothalamic pituitary hormone. So negative feedback happens when a product downstream of an axis inhibits the production of a hormone by which is regulated. So the upstream hormone, okay? Regulation can happen at the organ level, at the pituitary level, and at the hypothalamus level.
Yeah. The organ is primary, pituitary, secondary, hypothalamus, tertiary.
That's correct. So releasing hormones come from the stimulating hormone that comes from the pituitary gland. As an example, in primary hypothyroidism, T3, which is triiodothyronine, and thyroxine, which is T4, are low, whereas the TSH is high. Okay? So think about it. What could be the reason for that, right? So in secondary hyperthyroidism, TSH is low, as well as T3 and T4. All right? Now we're gonna talk about, we're gonna give you a case.
Okay, we're gonna do a case study now.
Yeah, we're gonna give you a case, and it sounds fun.
And that will end the talk for today. So we're gonna do the case now.
A 39-year-old woman complains of diarrhea, nausea, vomiting, lethargy, and dizziness. A month ago, she had a C-section complication that ended in hemorrhagic shock. Okay, a month ago. She had a C-section, remember that. Now, during the physical examination, we noticed sparse axillary and pubic hair, spurs, axillary and pubic hair, and there is depigmentation of the areola. Also, she has had difficulty lactating, and the blood work showed hypopituitarism. Okay? And she had an MRI that showed empty cella turcica. So what is the diagnosis here? The diagnosis, you can think about it. She had a C-section, she had a complication, and now she had a hemorrhage in her brain, and the pituitary suffered, and they just see an empty cella turcica. So the diagnosis is Sheehan syndrome, postpartum necrosis. Okay? Caused by infarction of the anterior pituitary gland. Why is the pituitary a target for posterior? No, why is the pituitary gland a target for shock and hemorrhage? after the pregnancy. Why? Because in pregnancy, there is hyperplasia of the lactotrophin, prolactin or secreting. Those are prolactin secreting cells. Remember, lactotroph in the pituitary gland, okay? There is hypertrophy of those cells, lactotrophs, which secrete prolactin, which we said. Now, without proportional increase in the blood supply, so the blood supply doesn't increase, but there is hypertrophy of the cells, okay? So that's the reason why it happens. Another question, why is the posterior pituitary typically spared in Sheehan syndrome? Okay? The posterior pituitary is untouched in Sheehan syndrome because the anterior pituitary gland has different blood supply than the posterior one, okay? The embryologic origin of the anterior pituitary is the Rathke's pouch, an endodermal evagination from the roof of the mouth, endodermal. The posterior pituitary is derived from a ventral outgrowth from the primitive hypothalamus, guys. Okay? Now, let's go for another question. Secretion of which hormones would be affected in this patient? Think about that. Is the anterior part, not the posterior, the anterior part of the pituitary gland. So we have a mnemonic that could be useful for us. There is flat pig. Okay, so FSH, follicular stimulating hormone. L, luteinizing hormone, LH. A, adrenocorticotropic hormone. T, thyroid stimulating hormone. P, prolactin. Okay. G, growth hormone. All right. Now, Dr. John, that's it for now. Okay, guys. Thank you for watching.
Thank you very much for watching. Like us, subscribe, and comment, please. Thank you.
We will continue working hard for you.